All right, so just wanted to give you time to sink in that last case, so I'm sure you guys are discussing. But I think what Nitin failed to mention is that that case demonstrates to all of us in this room that there is divine intervention. There is something above what we do. There's someone else watching over who makes those kind of results happen. So, Nitin, thank you for what you did for that patient. Amazing. But now I have a much more difficult task to introduce our keynote speaker. When I looked at his CV, I've seen a lot of CVs in my life, but I've not seen a CV which has an index for the CV. So there's an index of contents which you have to go through: education, papers, manuscripts, accolades, honors. So how do I introduce this person? How is that possible? So I'm trying to do my best about someone who has a CV bigger than the Harrison's Principle of Medicine. So I'll try to do my best here. This is Dr. Gregg Stone, who did his medicine from Johns Hopkins and then did his residency from Cornell. Went on to do cardiology fellowship in Sinai, and with Dr. Hartzman did an advanced fellowship in complex interventions. Since then, he had a journey from Lenox Hill to Washington Hospital to Stanford, Columbia, and finally now he's the director of the academic affairs and professor of medicine and School of Public Health in Icahn School of Medicine in New York. And then goes to the next stages. He has published not only published, he has been principal investigator in more than 140 landmark trials. Just think about it, 140. If we get one in a career, that's huge. This is 140. He has had more than 3,000 publications, manuscripts, where he has published numerous articles and books. And just to summarize that, his H index is 194. That means Nature Science, Nature Medicine, which is a very prestigious journal, mentioned him as the most prolific author in science. That's no mean achievement. And by the Web of Science as amongst the top 0.01% of cited researchers in science. He has the full spectrum from vulnerable plaques to structural heart disease to complex interventions to all the kind of pharmacotherapies, renal protection, cardiogenic shock, you name the field, and he's a pioneer in that. And now, he was the founder of the TCT. As you know, we all know TCT is the most important program till 2021. He was the co-director. He also has founded the Fellows course for interventional cardiology, also the CTO Summit, the TVT Summit that happens, and he also is a director and course director in at least 14 different countries where he runs these kind of programs. So I don't know where he finds all this time and energy, but he gave us today's date to give us the keynote address. So it's my distinct privilege and honor to introduce this year's keynote address, Dr. Gregg Stone.
Well, that was really a wonderful introduction. I'm speechless, but what I can't do is figure out how to feed all of you. And the only thing that's going to do that is by me finishing my talk so you can all go get lunch. So I'm really honored today to have been given the opportunity on behalf of the RECOVER-4 investigators to speak to you about randomized trials in cardiogenic shock as a prelude to RECOVER-4, and then to describe the trial with you, which we do think is going to be very important. These are my relevant disclosures. So I don't have to tell anybody that cardiogenic shock is really the number one unmet clinical need of patients that we see in the hospital. It's the greatest resource consumption, the most complex patients to take care of the highest in-hospital mortality. And when we talk about randomized trials in shock, there's no doubt there's one really important randomized trial. That's it. One really important randomized trial, and that's the shock trial that Judy Hochman led now over 2 decades ago. And this was 302 patients in shock who were treated with an early revascularization approach, either with PCI or bypass surgery, or with an initial medical stabilization approach and later revascularization if indicated in about 1/4 of the patients. And there was a substantial difference in mortality. Primary endpoint was actually 30-day mortality, and that was missed. But by 6 months, and then particularly at 1 year, there was a reduction in mortality. But still, it was 66% at 1 year in the control arm and 53% after early revascularization. But nonetheless, this, of course, changed the world, and we always try to revascularize as early as possible in patients with cardiogenic shock. So how did this translate to the real world? Well, if we look at the nationwide inpatient sample in the United States, we're talking about 2 million patients who presented with STEMI over this 10-year period, and about 7% present with cardiogenic shock. So with AMI cardiogenic shock, and that's what I'm going to talk about, it's about 7%. And if you look at mortality from about 2003 to 2015 or so, you could see that there was a reduction in in-hospital mortality from about 45% to 34%. Well, why did that occur? That occurred because the shock trial and increasing incidence and use of mechanical revascularization, in particular PCI. Still by 2010, only 50.7%. Obviously, it's increased since then. We don't have a lot of data since then on cardiogenic shock across the whole United States, but there's no doubt, I think it's getting a little bit better because of revascularization. On the other hand, if you look at AMI cardiogenic shock in the patients who are revascularized, who undergo PCI, for example, from the Cath PCI registry, this is 56,000 STEMI cardiogenic shock primary PCI patients, you could see over about a decade's period, actually the mortality is not only not decreasing, it's actually slightly increasing. So we are not making headway with mechanical revascularization in shock. It's the right thing to do. If we get patients early enough, we will salvage myocardium, we'll prevent infarct artery expansion, promote electrical stability, et cetera, but we're not doing a better job over time. So there's a lot of potential approaches. I won't go into all of that over time, but drug therapies have mostly failed. We can debate which pressors are best to use, et cetera. But myself and many other people are very interested in trying to make an impact through mechanical circulatory support. Because we all realize that if we're going to make an impact in shock, people have described that the first 24 hours, the so-called golden day, is when you have to intervene. First, by reperfusion therapy, by stopping the infarct, reducing infarct size as much as possible, perhaps by not adding iatrogenic medications such as pressors and inotropes that may hurt the heart. In contrast, unloading the heart, reducing wall stress, reducing infarct size and infarct artery expansion, and all the other complementary therapies that you're hearing about in detail throughout this course. We have to intervene fast and we have to intervene early. So mechanical circulatory support is certainly one way, and that's what Recover 4 is all about, of course, that we might be able to improve outcomes by either decreasing venous pressure, decreasing afterload, or improving coronary circulation. And of course, there's a whole variety of different mechanical circulatory support devices that support either the left ventricle and or the right ventricle and or the pulmonary circulation. They each have their own hemodynamic profile, which is unique, and they each have their own risks and potential benefit profiles. So we have one meaningful randomized trial of any of these support devices in AMI cardiogenic shock, and that was the IABP Shock 2 trial, led by Holger Thiel in Europe, 600 patients with AMI cardiogenic shock, randomized to a balloon pump versus no balloon pump. And you can see, and this is important, about 60% had STEMI, and about 40% had non-STEMI, and about 45% of patients had CPR before randomization. So immediately you question how many of these patients are even salvageable and how many are the right kind of shock. Maybe non-STEMI is going to respond differently than STEMI patients. I'll get into that later with when we talk about Recover 4. But nonetheless, he did this randomized trial, and you could see that there was absolutely no difference in the primary endpoint of 30-day mortality, about 40% in each groups of patients. And he followed the patients out to 1 year, and we've seen this pretty much in almost all shock trials with primary PCI as the base, and that is the vast majority of mortality is within 30 days. So you could see the mortality is around 40 to 41% at 30 days, and it's around 51% at 1 year. And of course, no difference between the two groups. So if you're going to intervene, you have to intervene early. We have to really reduce that 30-day mortality. Now, when you look at the other hemodynamic support devices, they all have different hemodynamic effects on what they do to left ventricular pressure, left ventricular size, pulmonary pressures, and even of how they affect the right ventricle and, of course, pulmonary circulation. These are pressure volume loops. That's not what you want to hear about right before lunch, but you can see just from the 4 different devices, balloon pumps, VA ECMO, tandem heart, and Impella, that there are very different effects on the left ventricle in particular. So if we were to choose the ideal mechanical circulatory support device, we would probably want one which would obviously support the circulation, that is, increase systemic perfusion, maintain blood pressure. We would want one which would support the ventricle, the left ventricle, and if necessary, the right ventricle. So we would want to decrease left ventricular end systolic pressure and volume and enhance aortic pulse pressure. And then we would like to at least not hurt coronary perfusion and perhaps even enhance coronary perfusion, the difference between mean arterial pressure and left ventricular and diastolic pressure. And you can see here the 4 profiles of the balloon pump, VA ECMO, tandem heart, Impella, and it's really only Impella, the transaxial forward flow device, that at least theoretically checks all of these boxes. And that's why myself and Bill O'Neill and Naveen Kapoor and Dan Burkhoff and others have been very, very interested in Impella, or at least similar types of transaxial flow support devices for a long time. So I do have to give a tremendous amount of credit to Bill O'Neill and Jeff Hartzler and Bill O'Neill and Cindy Grimes and Primary PCI were really my mentors and colleagues, and we worked on the PAMI series of trials together, and Bill and I were having a drink last night and reminiscing about the good old days. But Bill has really, I think, advanced our understanding of how to treat patients with cardiogenic shock through first the Detroit Cardiogenic Shock Initiative, which then morphed into the National Cardiogenic Shock Initiative. And what they did in this trial is they took certain patients with acute MI cardiogenic shock, and a total of 406 patients they've reported on at 73 sites. And these were selected patients that were not treated with mechanical circulatory support devices, that were going to undergo primary PCI, that did not have unwitnessed cardiac arrest, so they were at least neurologically recoverable, et cetera, did not have any acute mechanical complications of STEMI. And they put in place a standard protocol for treating these shock patients, including early initiation of an axial flow device, that is Impella, and always pre-PCI, not during or post-PCI. Invasive hemodynamic monitoring, right heart cath, an important guidance to additional medications, diuretics, and Impella weaning. Very careful and routine assessment of right ventricular function through measurements of PAPI and other indices, and the use of the Impella RP. If there is right ventricular failure, as you heard this morning, that's present frequently. And then weaning of inotropes and pressors as soon as possible, with the concept that these agents are probably deleterious because they whip the heart and they're not helpful in patients with shock. So if you look at where we kind of were before the NCSI, almost all the trials and real-world experiences are showing about 50% 30-day mortality. And now with NCSI, and this has been duplicated in several other experiences, they've got mortality rates that are significantly lower, down to about 25% or maybe 30%. But the question really is, how much of this is due to patient selection versus really the improvements in therapies that we're providing? So we really do need randomized trials because there's no doubt that the use of large bore transaxial LV forward flow support devices will likely, or at least have the potential, to increase bleeding, increase vascular complications. They're expensive, they can cause hemolysis, et cetera, et cetera. So we need randomized trials to understand if the risks are worth the benefits. And there have been a number of attempted randomized trials of Impella in acute MI cardiogenic shock. And as you can see here, just from the status, discontinued, 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 discontinued. The ones that are completed are very small, about 25 patients. So it's been very hard to enroll patients in shock. There's only been one, quote, successful trial in that regard, which is still ongoing, and that's the Danger Shock trial, which I'll talk about in a few minutes. And they're attempting to enroll 360 patients in AMI shock and randomize them to Impella versus nothing, basically, in AMI shock undergoing PCI. And they've randomized, as of a few weeks ago, 343 patients. So they are almost done, but it's taken them almost 10 years to do it. So a really Herculean effort. I thought COAPT was long, but this is 10 years. I mean, really extraordinary. And this will report out, so I will describe that soon. So why has it been so hard to enroll in cardiogenic shock? Well, there's been a lot of challenges. First of all, the populations are very heterogeneous, and do you enroll patients with just STEMI, with non-STEMI, anterior infarcts, non-anterior infarcts, RV infarcts or not? How do you define cardiogenic shock? That's not even widely agreed upon yet. What about the durations of symptoms and the duration of shock before or after PCI when you're going to emplace the Impella? A lot of people feel they know the answer here. If you look at, I don't have time to talk about all the registries, but there's a lot of registry reports showing that there are worse outcomes associated with Impella use in cardiogenic shock, and then there's an equal number showing improved outcomes. So which do you believe? It really depends on what your biases are. We have to acknowledge that it really is equipoise, that we really don't know, but a lot of physicians will not participate because their biases are so strong. They also think they know what the right technique should be, and that may not be the technique that you are putting into the clinical trial. There's a clear learning curve for the procedure and for ICU management. There's variability in the background medications such as pressors, inotropes, anticoagulants, use of reperfusion therapy, how the technology is used, how it's inserted, how it's weaned, etc. The technology is iterated over time. For example, from the 2.5 to the 5.0 to the 5.5 and CP in there, and then the RP device. There's been an iteration, as I told you, of best practices. Again, trying to rapidly wean pressors, use of hemodynamic monitoring, when to escalate beyond, let's say, an Impella CP device, etc. And slow enrollment because no one sees a lot of these patients, so that really leads to trial fatigue. And whenever you get past 2 years in a clinical trial, it's hard to keep going. In addition, perhaps the biggest issue is the difficulty in consenting these patients, because a lot of these patients don't present with a legally authorized representative, and a lot of them are not compos mentis. They can't give you support and consent. And in the United States, we cannot enroll those patients in randomized trials. It's much easier in Europe, where they are allowed to enroll those patients and then try to consent them post-procedure. But in the United States, there is a procedure which is called FACC, which is exclusion from informed consent, which is a difficult regulatory process to go through, but it is permitted by FDA and the regulatory statutes, but no one's done it yet in a cardiogenic shock trial to try to be able to enroll consecutive patients that can't give consent. So with this absence of data, where are we? Well, the most recent guidelines are the 2018 European guidelines on myocardial revascularization, and I guess what we both agree on both sides of the pond is that the routine use of intra-aortic balloon pumps is class 3. There's no benefit, at least from the IABP Shock 2 trial, although you can argue that that trial wasn't really done the way you might have liked to have seen it done. But nonetheless, it's led to a class 3 indication on, again, both continents. And in terms of using occasional support devices, now we get a class 2B level of evidence C recommendation. That's expert opinion. So really, the guidelines are saying we don't have any trial or even good registry data to give us guidance. So maybe you can occasionally use support devices, but you've got to use, common sense, and it doesn't dictate which you should use, whether Impella or ECMO or even a balloon pump on occasion. So because of this, there's confusion, as you would imagine. And if you look at the United States, we don't have recent data, but a number of years ago, mechanical circulatory support devices were used in about 50% of patients with AMI cardiogenic shock undergoing PCI. And then when IABP Shock 2 came out, the balloon pump use, which was the dominant modality, started to decrease a little bit, and Impella use was increasing. In Germany, and in most of Europe, it's about 12% of patients with AMI cardiogenic shock are getting mechanical circulatory support. The rest are treated just with pressors. And there's been a transition among those 12% from balloon pumps to VA ECMO and to percutaneous VADs like Impella, but that 12.5% is not budging. So this is Danger Shock, 360 patients at 13 sites in Germany, Denmark, and the UK. And again, they're almost done. But the important thing to note here, they're randomizing to, it was first the Impella 2.5, then they've transitioned to the Impella CP, and they've enrolled a lot of patients either before PCI, during PCI, or after PCI. And they also have enrolled a lot of patients who are already intubated with uncertain neurologic status. So this is going to be a very important trial, especially if it's strongly positive, but there's also already reasons for concern just in the trial design, but we're all anxiously, very anxiously awaiting this study. And Jacob Moeller, who's one of the principal investigators of the study, is part of our team and one of the co-PIs of RECOVER 4. So what is RECOVER 4? So this is a major effort that Bill O'Neill, Naveen Kapoor, I, and others have designed in concert with Abiomed and with FDA. It's a large-scale, multi-center, randomized, controlled, open-label, two-arm trial to demonstrate the effectiveness of Impella using a pre-specified treatment algorithm in reducing mortality in patients with AMI cardiogenic shock. And again, by providing effective left ventricular and, when necessary, right ventricular hemodynamic support prior to and during PCI, enabling rapid reduction of pressors and inotropes in AMI cardiogenic shock patients undergoing PCI. Our hypothesis is that an Impella-based treatment protocol will enhance myocardial recovery and reduce early and late mortality compared to standard of care, which is either PCI alone or PCI plus a balloon pump. So this is the basic algorithm. It's 560 patients, STEMI, cardiogenic shock, referred for primary PCI. Patients will be consented, again, either by, if they're able to give consent, or if they have a legally authorized representative, or by FACC. And then they'll be randomized 1-to-1 to either Impella, which will be the CP, plus minus the RP device if necessary, with a very standardized regimen, including hemodynamic monitoring, rapid weaning of pressors and inotropes, versus control arm, a standard of care, plus minus a balloon pump, and no Impella devices. There's protocols for escalation in both arms as to when to go beyond those initial randomized devices. Critical elements, this is 560 patients, STEMI only, with cardiogenic shock before the planned PCI. Again, we will recruit patients by FACC, exception from informed consent, which requires posting notices in churches and throughout the community and getting the buy-off of each individual community before you can do this, despite the fact that these are FDA-approved and labeled devices for this treatment. We will exclude patients not likely to benefit, especially those with uncertain neurologic status. There's nothing worse than getting an amazing hemodynamic save of a patient in severe cardiogenic shock and they never wake up. And those patients shouldn't be included in randomized trials. All of the randomization and the establishment of mechanical circulatory support will be pre-PCI. Again, use of hemodynamic monitoring to guide treatment and weaning, rapid down titration of pressors and inotropes, protocol-driven recognition of RV failure and use of RV support, and protocol-driven mechanical circulatory support escalation strategies when necessary. I won't go into all the details. These are the key inclusion criteria, but as I mentioned, definite ST segment elevation MI, and again, attendant emergent PCI to treat the STEMI, and a lot of exclusion criteria. But the key exclusion criteria are in red. We're excluding patients with ongoing CPR. Doesn't mean that they may not benefit, but you don't want to put them in a randomized trial because of what their very high mortality is going to be. We'll also exclude patients who have unknown mental status. We will include intubated patients if they had recently arrested and were intubated very quickly, and or if they're following simple commands while being intubated. And again, some more of the details which I've already verbally described. Our primary endpoint is all-cause mortality at 30 days, and we'll have 90% power to detect a reduction in all-cause mortality from 40% to 26.5%, a number needed to treat of 7 patients to save 1 life, with 3 powered secondary endpoints. So in summary, RECOVER 4 is an academically designed and organized trial that will be carried out under a US FDA IDE. It will determine whether Impella hemodynamic support prior to, during, and after primary PCI improves survival in AMI cardiogenic shock at 30 days, which of course we believe will translate on into later follow-up. This is a large-scale international trial that will incorporate all best practices that to date, particularly in the NCSI, have been associated with improved survival of patients with STEMI and cardiogenic shock undergoing emergent PCI. And finally, and most importantly, this is not going to be easy. We need all of you, everyone, no matter what your beliefs are, to acknowledge equipoise and recognize the challenge of US-based cardiogenic shock trials. So we need your enthusiastic support, both academicians and clinicians, to be able to enroll this essential study. Thank you very much.
Appreciation.
Just a small token of our appreciation of being our keynote speaker this year.
Wonderful.
Thank you very much for a great talk and for being here.
I'm really honored. Thank you, everybody.
Thank you.
So, all of you got the message loud and clear. In God we trust, but for everything else there has to be randomized clinical trials. To think about that, we need some food, so it's a lunch break. We'll meet after the lunch break. Thank you.